Welcome to GEMcast, the Geriatric Emergency Medicine podcast, where we discuss important topics in the care of older patients in the emergency department. I'm your host, Christina Shenvi. GEMcast is produced with the Geriatric ED Collaborative. You can find more episodes on any podcasting app, and you can find the show notes on the resources page of gedcollaborative.com. Welcome back to GEMcast. In the coming decades, we can expect to see a rising population of persons living with dementia. And there are a range of causes of dementia, but there's also, unfortunately, historically, not that much great treatment. There are some new medications that have come out specifically to target Alzheimer's dementia, are potentially going to offer some therapeutic benefit, but they're very new and there's still a lot that's unknown about them. This new class of medications are called Amyloid Targeting Treatments, but there are some important potential side effects that are associated with them and some potential risks of using one of the more controversial drugs in emergency medicine, namely TPA. I'm going to give you the bottom line up front. These medications, the amyloid targeting treatments, can cause some side effects of neurologic symptoms. And it seems like giving TPA to patients who are on amyloid targeting treatments may have an increased risk of intracranial hemorrhage. Here to talk more about these are two guests, and this will be part one of a two-part series. First, I'd like to welcome Richard Isaacson, who is a neurologist and director of research at the Institute for Neurodegenerative Diseases in Florida. Richard, welcome to GEMcast.
Thanks so much for having me, and I look forward to the conversation.
And Kevin Biese, who is an associate professor at UNC Chapel Hill and directs the Geriatric ED Collaborative and Geriatric ED accreditation programs. Kevin, you've been on GEMcast before, but great to have you back.
Thrilled to be here. Thanks so much, Christina.
I'm your host, Christina Shenvi. And before we can dive into these new medications and their potential side effects, I want to back up and review the importance of this topic. Currently, there are 7 million people living just with Alzheimer's, not other types, just with Alzheimer's dementia in the US. And 1 in 3 older adults dies with or of dementia of all types. And the 2024 projected health and long-term care costs related to dementia just for this year in the US are $360 billion. And that's anticipated to rise to $1 trillion per year by 2050. And if you think about, well, what's the lifetime risk of Alzheimer's disease? If you are at age 45, which is my age range, we'll say, your risk is 1 in 5 for women and 1 in 10 for men, your lifetime risk of developing Alzheimer's. And Alzheimer's disease affects not only the individual who develops it, but also their family and caregivers. There's a huge caregiver burden for family members of patients with dementia. And there are about 11 million people right now providing unpaid care, meaning family members, for people living with dementia, Alzheimer's dementia. So it's an incredibly important condition for individuals, for family, for society, for healthcare, for our economy, given those numbers, 1 trillion. And we're going to be covering this major new class of drugs that target Alzheimer's disease, which if we can reduce the symptoms, reduce that caregiver burden, reduce the healthcare costs, that is incredibly important to healthcare and to those individuals. But first, we need a little refresher in order to understand these drugs on the pathophysiology of Alzheimer's disease. So, Richard, can you walk us through briefly how Alzheimer's disease develops and how long in the disease process it is till symptoms manifest?
Sure. Well, first of all, I think it's surprising, but most physicians and also the public is really unaware that Alzheimer's disease begins silently in the brain, decades before the first symptom of memory loss begins. And, that leaves a lot of time for people to intervene. And I think one day Alzheimer's dementia is going to be thought of as a disease that we try to prevent in terms of primary prevention, secondary prevention, just like heart disease or stroke when the atherosclerosis builds up for decades before you have an event. It's the same thing with Alzheimer's disease. So first, there's a conceptual shift that I think most people are just not aware of just yet. When it comes to the exact etiology, well, that's still somewhat unclear. A lot of debate, although one of the prevailing theories that we'll talk a lot about today is that amyloid, this protein, this pathologic protein that builds up in the brain silently, at least 10 or 20 years before the amyloid starts building up. And then whether that triggers or is associated with another protein called tau, these tau tangles, neurofibrillary tangles, and then through either a combination of inflammation, neuroinflammation, or a combination of amyloid and tau, the brain cells start dying. That leads to neurodegeneration, shrinkage of the brain, and that's really a more characteristic of the dementia phase. Now, are there other aspects? I think sure. There's modifiable risk factors. We won't go in that here, but I think there's many roads a person can take to Alzheimer's disease.
We've got these amyloid proteins, and my recollection is they're a normal protein, but then they misfold into the amyloid shape. Is that right? And they're deposited in the extracellular space.
Yes, exactly. And the depending on how the anti-amyloid drugs are really concocted, different anti-amyloid drugs work on different types of amyloid. So the oligomers, the protofibrils, the mature fibrils, and basically anti-amyloid drugs have honestly been around for 20 years. I think most people also are unaware. I put my first patient in a phase 2 trial on anti-amyloid drugs in phase 2. That was 2006. These drugs have been around even longer than that. But the goal here is to try to reduce amyloid. And if you can reduce amyloid, that can also reduce tau levels as well, based on clinical trial evidence. So depending on the type of anti-amyloid drugs and what it targets, it can actually work in a variety of different ways.
So, if we move to these specific drugs that we're talking about, these amyloid targeting therapies that are monoclonal antibodies, how are they working?
Well, so they're trying to, lower or bind to or attack different types of amyloid proteins and different shapes and sizes. So basically, the initial drugs, the initial anti-amyloid drugs, kept failing and failing and failing. But what the field learned is that either the patients didn't have amyloid, because back then we didn't even have amyloid, screening tests or biomarkers. So either the drugs failed because they were given to people that didn't have amyloid in their brain, or the drugs failed because the wrong type of fibril was basically targeted. So I think the failures don't necessarily mean a future of failures. The failures, to me, allowed for a lot of really necessary learning.
And which patients then are good candidates? How do you determine at what point in their symptom course or in what point in their level of amyloid deposits that they are now a good candidate for these drugs?
Yeah, and this is a really important question because, there are millions and millions of people with Alzheimer's disease, but most of those people have Alzheimer's disease dementia. And people with, the moderate and severe phases of Alzheimer's disease dementia, that person's had Alzheimer's disease for, decades. And these drugs are not suited for those patients. Patients with more advanced dementia trial and time again just have failed. So the really critical aspect here is the earliest phase of symptomatic Alzheimer's or the mild cognitive impairment phase. And I think people think of the older dementia patient coming in and maybe that's the person I should be worried about giving TPA to. But I mean, drugs can be, of course, given off label, but the elderly demented patient that hasn't spoken or really doesn't interact with people, they're not going to be likely to be on these drugs. It's going to be people with mild early Alzheimer's disease dementia. So I think people have to kind of frame shift a little bit because I have people with mild cognitive impairment that are on these drugs that are running businesses. A little bit of help here and there, but people with mild cognitive impairment can still take care of themselves and they don't have dementia. People with MCI can be living very active lives. And I think in the ER setting, you kind of have to frame shift a little bit around that. The other thing is people who are not on, anticoagulants, people who are on aspirin, maybe. I think that's possibly okay. Like when you have a patient that comes in and I want to do everything I can, okay, maybe a baby aspirin is okay. But people on anticoagulants, I wouldn't use anti-amyloid drugs in the outpatient setting, too risky. Also, people that are willing and able to have regular follow-up and close monitoring. This drug is not a pill, not just like, take this thing and see in 6 months. Person needs to be, first of all, diagnosed with Alzheimer's disease with amyloid. So either a PET scan or a spinal tap. Soon the blood test will be overtaking these things more cost effectively and just as accurate. But until then, we have to have people that are able to pay for a PET scan, a lot of times not covered by insurance. Once they have amyloid that's certain, then they have to have an MRI to make sure there's no baseline swelling or bleeding, because that's a contraindication to using anti-amyloid drugs. And there really needs to be a good support system for side effect monitoring. Also, ApoE is a risk gene. It doesn't mean you're going to get Alzheimer's disease, but if you have the ApoE4 variant or 2 copies of ApoE4, that increases risk, but it also increases risk of side effects to anti-amyloid drugs. And the people that I'm worried about on anti-amyloid drugs for side effects are the people with 1 or more copies, especially 2 copies of the ApoE4 variant. In an ER setting, we're not going to be checking ApoEs on people. That's not going to happen. But In the outpatient setting, it's commonly done. So, maybe those are questions that can be talked about too.
And how good is the evidence for how well these work? You mentioned it doesn't reverse the existing cognitive dysfunction, but how
Mhm.
well does it delay progression?
Yeah, great question too. The best thing I ever heard in terms of a summary on how these drugs work are it makes people get less worse. Anti-amyloid drugs do not stop the disease in its tracks in most cases. You can't expect improvement, but they delay the expected progression of the neurodegenerative disease and the cognitive decline. While it doesn't necessarily improve cognition, I've absolutely had cases that, definitely not placebo. They're getting the real thing. We've done the repeat neurocognitive assessments. We've talked to the caregivers. I've seen them myself. I'm 100% sure that in the right patient, at the right dose, for the right duration of time, these drugs can absolutely be effective. But just like we have these cancer drugs where you hear the commercials and they say, oh, this person negative and this gene and this, that, and this, whatever. We're like in a baseball game, we're like in the first and second inning of, anti-amyloid and disease modifying therapies for Alzheimer's disease. And these drugs on the grand scale work okay. They slow progression, maybe by 25 to 35%. That's pretty good. Buys you a year or two out of every 3 or 4 years. I'll take that for my loved one, even though there's a cost. But these drugs cannot be expected to be a grand slam in every case, but certain people, they work quite well. And I think it's only going to be a matter of time until we tease that out even a little bit more.
Now, before we get into this complication that can be seen from the drugs called ARIA or amyloid related imaging abnormality, I feel like we need to address one of the elephants in the room, which for me is the cost.
Mhm.
Alzheimer's disease is an incredibly common condition, and as our population ages, it will become even more prevalent. So, what are your thoughts on how many people will be on these drugs? How will it be paid for? And what is the cost associated with them?
Yeah, so in terms of cost benefit analyses and truly understanding what is the value of these drugs, I think that's a tough question to answer. Currently, most of the patients that I've put on these drugs have had to pay out of pocket. These drugs are not inexpensive. These drugs, it depends on how much you give, also the dose. And, I tend to use smaller doses and a very small and slow titration. And the lower the dose, the less expensive it is. But once you're on the maximum therapeutic dose that was approved by the FDA, then it's just over $2,000 a month for the current FDA approved drug. So that's about $25,000 a year. In my clinical practice, because of trying to mitigate risk of side effects, I've actually never gone to the full dose, and that can be a whole different discussion on its own. But I think, again, the cost is there, but if we can mitigate risk and we can use it early enough, I do think the cost benefit can be there.
Yeah, that'll be an interesting discussion from the healthcare economic side because, yes, if you can reduce long term care costs and keep that person productive and working in society or being able to be independent, maybe that can save $2,000 a month. But I don't know. That's a hefty price tag.
Yeah, and I think it depends on the person and depends on the family too. These are very expensive, and this will be covered more and more now that FDA has fully approved, and then of course there's other drugs that are being discussed right now. But I do think insurance coverage will morph quite a bit. But it's not just the drug itself; it's the multiple MRIs, it's the infusion, it's the doctor's visit. There's just a lot of stuff that goes into it, not just the drug itself.
Mhm. So now let's jump into this potential complication that can happen with these drugs, which is called ARIA, amyloid related imaging abnormalities. And it's called an imaging abnormality because most of the people who have it only have imaging changes. They're asymptomatic. And it took me a little while to really fully understand this, but ARIA occurs in about 30% of patients taking these amyloid targeting treatments, but only 6% of them were symptomatic. And there are two main patterns of imaging abnormalities that can be seen: ARIA H, which is microhemorrhages, and ARIA E, which is edema. So maybe you can walk us through the pathophysiology of what's going on here and how people started seeing this on their screening MRIs.
Sure. So when it comes to brain imaging, we use MRI, magnetic resonance imaging, to look for the potential emergence of ARIA H or ARIA E. Why does ARIA happen? Well, we think it's caused by the increased vascular permeability that follows an inflammatory response. Honestly, when I used to see a little bit of swelling, a little bit of edema in a person's brain when a person was in a clinical trial, and this is, almost 2 decades ago, I would actually be excited. Well, I'm not mean. I don't want my patient to be hurt, but I would be excited because I knew that the person that I cared about, that I was trying to, get the best treatment out there possible in a clinical trial, was getting the real drug. And because I also noticed that the lion's share of people that had ARIA, RAE, in the case of edema, didn't have symptoms, were completely asymptomatic. And whether it's 30 or 40% of people in the trials that get these side effects, and it really depends, honestly, on the ApoE. People with 2 copies of the ApoE4 variant are going to be at much higher risk of having ARIA for sure. But when it comes to the symptomatic side, a very small number of people, 6%, 5%, 3%, 8%, depending on the trial and depending on, what you define as symptomatic, people are generally not symptomatic, and these things thus have to be monitored. And there are physicians out there that, despite ARIA, will still continue on the drug. They may pause it for a few weeks, pause it for a month. But when it comes to what this actually is, whether it's vascular permeability and that inflammatory response that happens, and it leads to this extravasation of blood products and proteinaceous fluid. Now, people with cerebral amyloid angiopathy, CAA, they actually have a very similar pathogenesis to that of ARIA, and it's really a lot of overlap in terms of a differential diagnosis. But the imaging findings really are essentially the same for both entities, and only a history of monoclonal antibody use can help with differentiation.
And it makes sense that you would see some edema or vascular permeability because you're intentionally, that's what you're doing, is you're recruiting your immune system to attack and phagocytose the amyloid. And
Yep.
so it's not surprising that you would get some edema because that's part of what the immune system does. But here's the crucial part. So most of those patients who had ARIA were asymptomatic. When they did have some symptoms, what were the symptoms that commonly presented?
Yeah, so this can be quite variable and also, to be honest, quite subtle. I've had this happen in patients that I've followed, for years, patients that I have known for honestly decades, because I've known, treated a friend's family member or something like that. And it's really can be nonspecific. So I want to just start with that. It can be subtle, nonspecific, and really challenging. The first thing I would think about, generally speaking, is a headache, some confusion. Also, depending on where the ARIA is, you can have different symptoms. If someone has severe ARIA or sort of severe ARIA-H, for example, you can have vomiting, you can have visual disturbance. If, for example, the swelling or the bleeding is in the occipital lobe, you can also have gait disturbance. So, the challenge here is it's so, heterogeneous when a person has ARIA. But if I had to choose just like I don't know, 7 times out of 10, there's usually some degree of headache, confusion, something just feels off, someone is a little slower. Sometimes we ask, oh, I wonder if a person with early dementia has a urinary tract infection or is getting sick or something because they're slower or something. Oh, but wait, they're on an anti-amyloid drug. We better scan them because let's check their urine, let's do the blood, but we also have to get an MRI. So I wish I could have a better, clearer, a more perfect answer, but this is nuanced and really challenging.
Well, and now this brings us to the ED, because for the ED audience, the concern is how might these patients present to us and what do we need to know and what do we need to do? So, Kevin, you've been thinking about this complication and its implications for a while. What are your thoughts on how we need to prepare or what we need to consider in patients who are on these therapies?
Oh, absolutely. Thanks so much. And first of all, I just want to say I'm thrilled to be on this podcast with Richard. Most of our ED audience isn't going to be as familiar with Richard's work as a lot of the neurological colleagues are out there, but Richard has been on the cutting edge of how we confront dementia, how we help stop it, how we get in front of Alzheimer's for years. If you do a little Google search, you'll be like, oh my God. And I say this in the complimentary way. He's kind of the Elon Musk of dementia prevention in this country in a good way. I realize Elon has a lot of mixed characteristics today, and you have better clothing styles than he does based on some of the recent late night shows I've seen. So I'm going to talk about concerns, but I am grateful that you're doing this. And I'm grateful that we're beginning to have therapeutic advances that seem to go directly to the disease-causing etiologies of Alzheimer's dementia. Regardless of whether these specific medications, like lecanemab or others, were completely well thought out in their release upon the market or are the quote-unquote right answers, they represent a seismic advance in how we deal with a disease that is crippling and terrifying for almost all of us and our loved ones. So thank you, Richard, for everything you're doing. And Christina, thank you for having this podcast. My other comment would be, this might not feel like an EM podcast. We're talking about dementia, but I'd invite you to go stop by your ER and look around. You're going to see people with dementia there, and you're going to be painfully aware that we're failing as a whole system to meet the needs of them and their loved ones. So I think this topic is just spot on for us. Okay, so ARIA and, anti-amyloid targeting therapies. I think we have to think of a couple things that are just critical, Christina, and I imagine we'll follow up on them in the next podcast, but there's just some really critical considerations here. Consideration number one, it can look like a stroke, right? As Richard just said, 30% of the people that are on these medications, give or take, have microbleeding. You know what we tend not to do for people that have bleeding in their brain that look like they have a stroke? Is give them lytics. We tend to think that's a bad idea, that's not the right treatment, right? So stroke complication is hugely important, and there are now case reports of death of people that got lytics when they were on these drugs. Now, is that causal? I don't know. There's case reports of death of people getting lytics that weren't on these drugs. So I want to be honest about that. But it is certainly cause for concern that these drugs have a very high risk of small amounts of bleeding, that those bleedings can be associated with symptoms that look like stroke. And our usual stroke pathway, which is, when did these symptoms start? Get a stat head CT. You don't see bleeding, which of course you don't see ARIA on a head CT. Give them lytics if they have a high enough stroke scale, may be fatal. So that's concern number one. We've got to get out there in front of this and think about how we build into our standard stroke algorithms your institution's approach to intervening on people that are on these drugs. Which brings me to point number two. We have to know if our patients are on these drugs. Frequently, when patients roll in with a stroke or any other complaint, we have a very incomplete drug list, especially in conditions that we have to make rapid decisions on whether to use, significant interventions like lysis on quickly. Because as we all know, it's not like before 4.5 hours good, after 4.5 hours bad. You're losing efficacy of our interventions as time goes on. And so there's pressure in that room to make rapid decisions. And so we need to know if these patients are on these drugs. Now, I've had the privilege of talking with systems around the country that are administering these drugs over the last month. Within the system, they are beginning to develop care pathways for knowing these patients are on these drugs or who to call when they show up in the ER. But of course, patients don't always just stay next to their own hospital. Sometimes they visit family or travel. Sometimes they get taken to a different hospital, and we've got to know when these patients are on these drugs. And one final umbrella comment about things we need to consider. If you listen to what Richard was just sharing, and of course he's correct, almost any neurological symptom could be secondary to ARIA, and the only way to diagnose it is an MRI. Thank God all ERs have MRIs that function 24/7. Oh wait, they don't. I don't know the exact numbers, but I'd wager to guess most ERs don't have MRIs. And if they do, they don't function 24/7. And the cost at both a personal and a financial level of transporting patients all over the place to get MRIs is staggering. Now, we can say, gosh, you should call the neurologist that gave these. And of course you should. But again, it's complicated because they don't always come to their home ER. You're not always within the same system. So the fact that the only way to diagnose symptoms secondary to ARIA is with an MRI, and those symptoms can be incredibly subtle, to quote, is really a challenge as far as how we deliver emergency care. And I think these are things we need to be thinking about now, and we all need to be thinking about before these patients arrive in our ERs.
Well, we're going to leave it on a bit of a cliffhanger there because Kevin has just gone ahead and popped open a giant can of worms. And that's what we're going to dive into in part 2 to really parse out, okay, what's going on? How would we approach this? And right now, we need to hold the data with open hands because there's little of it and it's rapidly changing. But to recap what we've talked about right now, Alzheimer's dementia or Alzheimer's disease develops over decades with amyloid and tau deposits, and there haven't been great treatment options. So it's very exciting that now we have some drugs that can potentially make it less worse, as Richard said. However, there are some side effects, and that's where we come in the ED, because guess where people go when they're having random nonspecific neurologic symptoms? They come to your neighborhood ER. So with that, we will continue next time to talk more about the potential complications and risks of giving TPA to these patients. Thanks for listening. See you next time. Thank you for listening to this episode of GemCast. You can connect with me on Twitter with the handle @GemPodcast. You can also navigate over to gedcollaborative.com for more resources on the care of older patients.